Thank you for introduction. Uh, so we are. It's not the. Yes. Okay. So we are going to talk again about the perfusion markers for the tumor imaging. So we will see a little bit the inside also about the question that was asked just before about the PET correlation. Um, so the tumor imaging, we know it's quite difficult. So first of all, there are problems in initial tumor management. When we discover a lesion, we need to know to try to orient ourselves to know what kind of lesion it is, how should we grade it, and also are we going to primarily resect it or to do a biopsy. Then the second problem is that while we are treating our lesion, we will eventually have the contrast enhancement that will appear. And then if we are doing our RANO, we will say, oh, wow, it is a progression. And usually in the reports I put, okay, following to RANO, it's a progression, and following myself, it's not. So we cannot always trust only the contrast enhancement, and we should know if actually it is progression, and then we have to change the treatment, or if it's radionecrosis or pseudoprogression, and then we should not change the treatment because it is eventually the only vision treatment for the patient. So we can do the follow-up, usually with RANO. We're doing follow-up, we're looking at the lesion. If it's modifying, we say, okay, it's increasing its progression, it's decreasing, it's not a progression, but then we are going to lose time and to make a lot of mistakes. So there were a lot of different markers that were introduced for the years. So we are looking at the flare to see if it's more edema or infiltration, but we cannot always know. We are looking at the diffusion to see the restriction, but as it was well shown in the talk before, when we look at the papers, we have these nice diffusion images where we can actually say something, but in the real life, diffusion in tumor is very complicated. And of course, we have the perfusion. So when the perfusion was introduced, the used perfusion marker is technique is the C perfusion with contrast injection, and so we are used to look on the RCBV maps. And if the RCBV increases comparatively to a region that we should choose, we say, okay, it's probably a progression. And if it's not increasing, or if there is a blood barrier disruption, as we can see here, I don't think I have a pointer. Down the images, no, we don't have the pointer, okay. So then we say, okay, this is radonecrosis. And actually, when we look at the, yeah. Oh, now I have a pointer. Great, thank you. So actually, when we look at the studies, the results are not perfect, but they're not that bad. But when we are looking at the thresholds, then there is a real problem, because the thresholds across the studies are so variable. Then when we are looking at our individual cases, then we don't know what to say. We don't know if it's an eventually progression or radionecrosis. So there are also other problems. So there are the anti-angiogenic treatment that can give us the images that look like there is a response, and actually there is still some progressive tumor. And also we have a lot of artifacts, because the sequence is API based, and the patients, they are usually treated by surgery, then by radiochemotherapy, so there are a lot of bleedings, and we can have a lot of artifacts. And so if we are doing basic treatment without correcting the artifacts, we can get this kind of maps that we don't actually know what is happening in this tumor region. And another major problem is the issue of prognosis. So we can see the contrast enhancement. We can say, okay, there is a perfusion, and then, okay, does it mean that the lesion would continue to progress or not? And sometimes we don't know. So another contrast that was proposed is the arterial spin labeling. So it's without contrast injection. We use the endogenous spin signal, and we make the difference between the marked spins and the control, and we deduce the cerebral blood flow. So in the classical sequence, that is only one post-labeling delay, we have a CBF only. But what is interesting that sequence is quite dependent on providers, but in some have less artifacts. So like in this case, we've seen that we cannot respond. Here in ISL, we clearly see that there is an hyperperfusion. But when we look across the studies, the results remain still imperfect, and we cannot always say if it's progression or adonecrosis. So then the PET markers were proposed to help us to answer this complicated question. So the most available and most frequent PET marker is FDG. The problem of FDG in tumor imaging that there is a strong brain physiological binding, and there are a lot of specific binding like in abscess, inflammation, neurocircuitosis, and it's difficult sometimes to say if there is actually a binding or not in the tumor. It's very good for lymphomas, but for other lesions we cannot really trust it. So then amino acid traces were proposed, like DOPA and FET. They have some difference between them, but usually we choose the one that is most available. Like we have DOPA, but in some other centers they have FET. And we will compare the burden of the lesion to the striatum, and then we will say, okay, if it's stronger, then it's probably the progression. If it's lower than striatum, then it's probably radionecrosis and there is no progression. Well, still the sensibility specificity remains imperfect, and also the problem is the availability, because the tracer is expensive and you need to have the cyclotron to produce it. Like in our center, we can do 4 exams a week with it, so we have really to well select the patients that should benefit. But this is something that was published, that there is a real benefit to do PET MR as comparatively to MR only, both in primary brain tumor assessment and also for progression detection. And there is a real modification in the management of the patient between if we are doing MR only and if we are doing the PET MR. In PET, we can also do some fancy stuff, like we can look at the dynamic PET to see if the curve is more corresponds better to the tumor progression or not. But the problem is, first of all, we were saying that it's not always perfect, it's not always available, and also in the study we have shown that there is no perfect coincidence between the abnormalities that we have in perfusion and the ones that we have in PET. So the PET is not something that is going to replace the perfusion. And in this study, we have also seen on how different markers would interact, considerably considering also the bleeding. So when we take all together, it's not perfect, but it's not bad, and we will have the classical, here we had the ISL only. It's not that great, even if it's helpful. So we need to go further. And so in this context, we have the new biomarkers that were proposed with the vascular analysis modeling that allows us to have less noise and artifacts. And you have seen how it is important to have less noise and artifacts, especially in the question of follow-up when it's a real issue. And of course, well, the first thing I should always look, we will see the examples and the corrected cerebral blood volume, corrected for the leakage that we can have in the tumor. So this is something fundamental. And then to go further, we can have also another markers that we propose, the one for capillary transit time heterogeneity that I have already seen a little bit, also the oxygen extraction fraction and CMRO2. So we are doing now a study to compare these different markers also to PET. We don't have the results yet, but I will show you some cases to illustrate how it can be used. So first of all, first assessment. Okay, so here we have a big tumor, there is no doubt. And the problem is that we cannot completely resect it. So we have to do the biopsy. And then the question in this kind of huge tumors are where to do the biopsy. And the interesting thing, when we look on multiple maps, we have here, there is, so it's grade anaplastic oligodendroma, grade 3. So here we don't have the contrast enhancement. And there is a large hyperperfused region, but only one part of the region has the increased CTH. So probably we can suppose that this will be the region where the biopsy will be most interesting. Another case is this patient. So we discover with the headache, dizziness, this tumor lesion. And when we have cortical subcortical lesions, it's very difficult to look at the RCBV map because there are a lot of vessels, and here we cannot say that it's corresponded to tumor. It can be eventually vessels. But when we look at CTH and OF, then we can actually see that it corresponds to this lesion. And the patient was operated, and after the surgery, he has a TAP, and this was quite early. So this is a little limit that we have on CTH map. Then when it's on the cavity, then we can have some noise in it. So this is something that we can correct now with automatic segmentation. We'll see later. So this lesion was resected. But what was interesting that there was another lesion. And actually, it was discovered initially, this lesion, but because it was doubtful, we did nothing about it. But when we look, well, there is an hyperperfusion in this lesion, but the CTH is completely normal, and also F. There is no modification. And actually, this was not a tumor lesion. It is progressively regressing on the follow-up. There is no PET uptake, and probably it was a little ischemic lesion in this level. Another story from the first assessment to follow up. So, okay, here there is a lesion that looks very bad, aggressive, with increased MRO2, CTH, everything. So there is quite no doubt. The patient was operated. It was glioblastoma. And then there was the follow-up, where we had this contrast enhancement that appeared. The question was what this corresponds to. So when we look on CBV map, again, cortical lesion, we don't know. But when we look on CMRO2, then we can see that there is something that really is different from from other vascular regions, and maybe there is something happening here. And indeed, there was something happening here. He had a PET 2 months after, and here we can see also the OF increase, and that coincide with this increase of PET dopa uptake, and it was a progression. Another thing, sometimes it can also indicate us maybe what will be happening later. So this is grade 3 oligodendroglioma, and here everything is going fine and follow up. This was a retrospective reconstruction, we didn't know that time. And actually there is this region where CTH is increased. And then time passed, patient is followed up, and actually, quite some time later, there is exactly the progression that appears in the region of CTH increase. Well, it's a lot of time. The question is, should we operate him before or not? Maybe, because if not, if we would do it, the progression would not occur. So it's something that would be quite interesting to explore. And also interestingly, you can see here that it coincides with the Doppler increase, and we see nothing on FDG. So in FDG, as we say, there are a lot of false positive cases and also false negative cases, so we don't know. Another story that I wanted to illustrate you is about the leakage correction. So here we have the patient with glioblastoma, surgery, radiochemotherapy, and finally he was treated by CCNU and Avastan. And there is this necrosis that you can see, gelatinous necrosis that you can see here in high T1 signal, but around there is also some contrast enhancement. So we want to know what is this contrast enhancement about. And if we look at the RCBV, then we see that there is some little increase of perfusion in this contrast enhancement. But when we look at the leakage map, actually all this increase was just a leakage. And when it's leakage corrected, there is nothing that remains. So it was radionecrosis, and we confirmed it based on the PET study also that was negative. Another problem is that all these lesions, as said before, that can have several compartments. So there could be a part that is actually progression and the part that is not. And particularly when we want to go to the biopsy, we don't want to biopsy the necrosis, we want to biopsy the progressing lesion. So it's important to know where we are. So here, if we look on this contrast enhancement on after radiochemotherapy, we see that there is a contrast enhancement that is quite in the deep region, but also superficial. And there is an hyperperfusion on the deep part, but we don't want sometimes to biopsy in the deep part of the region, and we want maybe to get something more superficial, and there is this superficial enhancement. But is it a lesion or not? So when we look deeply, here on RCBV, again, superficial is difficult. But when we look on OF, actually in the superficial part, we don't see much. So is it progression or not? Let's look on the PET. And so when we look on the PET, we suppose that in the deep part there is a progression, but in the superficial part, actually, there is not much enhancement. It is all inferior to striatum. So probably the part that is peripheral was the more necrosis-related contrast enhancement, and the progression was only in the deep part. So actually, well, if we would go to biopsy the superficial part, we would not get the tumor there. So this is something that we could probably deduce already looking on OF. Another story, this is also always same question, progression or radionecrosis, but here there is something interesting that can show us why it's interesting not to choose only one map, but have several maps. So, well, first of all, we have this contrast enhancement. We don't see much on RCBV, this happens. On PET, it's kind of intermediate, it's equal to striatum, so we're a little bit in the gray zone. And here we have the increase of CTH and OF that coincides with the gray zone of the PET. And so supposedly it was a progression, but particularly interesting also was the second lesion, because there was this cavity lesion, and we say, okay, probably this cavity lesion is necrosis, so such a cavity. But there is still a PET uptake that was little superior to the striatum, that was suspicious. And also when we look, there is exactly the same profile. That there is the same profile on CTH and the same profile on OF. So actually having the multiple markers, we can better describe the profile of this lesion, and both of them were progressive. So another example where we can predict the lesion progression, we had this contrast enhancement here. We don't know what to see about the RCBV. With correction, we have something, maybe something comparatively to the white matter. And on SCOV marker, it's quite increased. And when we compare to PET, there was a strong increase also on PET. And this 1 month later, finally, the patient was followed up. It was better to change the treatment immediately because 1 month later, there was a real progression that was quite strong. So here it's a little bit similar to a case that I showed you before on 3 years progression, but here we have something. We have a little increase on NCBV and on CTH. And in the superior part, we don't have no increase at all on any of this marker, almost nothing on CTH, very low, and nothing on CBV. But it was not progressing, so over the years we'll follow up, and then finally it ended up by progressing. So here there is a real strong increase of CTH in the same region, and the increase of the perfusion, and it's also hypermetabolic. So it's again the same question when we see the scenes before, whether do we see them only on CTH or we also see some little hyperperfusion. Even if it's not progressing immediately, we suppose that maybe it will end up by progressing and we should treat earlier. So also on prediction progression, sometimes it can be quite impressive, like here. It's patient that was under chemotherapy, temodal, a regular follow-up, everything was going great. But if we look on OF, so it was also retrospectively analyzed, we have this OF increase here that appearing. It was not here before. And actually, 2 months later, there was this lesion that appeared here that was exactly coinciding with the OF increase. So when it's increasing, probably it will happen sometimes in 3 years, sometimes in 2 months. So this is something that we should better analyze, and we also will use our multicentric study to analyze this. And maybe by the measurements, we would be able to predict if it will happen sooner or later, because this is also something that is important in the patient prognosis, to know the time and when it will happen, actually, even if we think that it will. And just to show you this new feature where we can segment the lesion. So here there was this case where there was no enhancement in the beginning, and this is the new lesion that is enhancing. So then it can compare over time, and we can also have our necrotic mob volume. That is interesting because we can put it on our CTH maps after to exclude everything that is necrotic to do the measurements. And just also this case that is quite interesting here. Well, we are sure that there is a contrast enhancement, there is something happening, but no perfusion. And again, we have our CTH and OF that is increased, and also something going on in PET. And 6 weeks later, it's increased. So same question, how to know when it will, we know that it will increase now, that how to know when, this is something that we should study more. And sometimes it can also help us in the opposite way. So here we have this hyperperfusion, but the CTH and OF are completely normal. And we were following this patient, and we still had the same hyperperfusion profile, the same profile. And actually, 2 years later, instead of increasing, the lesion decreased, and still had a good profile on CTH. So maybe it can also predict as the things other way around. Let's say, okay, there is nothing, so maybe even if there is some active tissue with neoangiogenesis, maybe it's still not progressing. And here it was predicting better than PET, because in PET it was hypermetabolic, and you see 2 years later, same treatment, no changes. The hypermetabolism also decreased. Also, so this was for the glial lesions. Also, sometimes it's interesting to look on other lesions. So here we have this man, probable glioblastoma. So something what is interesting with multiple markers is to see that all the markers coincide exactly. There is no difference. So there are no different tissue components. Why? Because it was not glioblastoma, it was a secondary tumor, so everything was quite homogeneous before treatment, and patients were operated and he was fine. And also we can look in this on this kind of lesions. Well, with this increased diffusion, we can suppose the diagnosis that it's actually a lymphoma. But what's interesting that, of course, when we analyze the perfusion for lymphoma diagnosis, we really need to look at the leakage and the leakage correction. So to conclude, we have all these new markers. So what is interesting is now to do the study to see how they exactly correlate with PET, what is, and how can they can predict the progression, as we saw on these examples. Sometimes they predict the early progression or late progression. Could we do the measurements to see which time it predict, how it predicts the timing? So this is something that is now under the analysis. Thank you for your attention.
Thank you very much, Nadya. Very exciting to see the beginning of your study here. Questions from the audience?
Thank you for your presentation. Just one question. We had few cases where, tumor effective, MS. We haven't realized it was that, so we biopsed. Have you any experience with that?
Sorry, with what?
Tumor effective.
Typer?
For MS.
For MS?
Yes, there's been some cases where we thought it was tumor, but it wasn't.
And it was.
So, do you have any experience with this?
No, we didn't have experience on measuring the markers on MS, but it's interesting to look retrospectively if we have some cases on fast assessment to look what it gives, but for now we don't have any.
Hi, and Nadya, thank you so much for an amazing talk and really lovely images. Can you tell me about your experience on non-enhancing tumours? Has the CerCare software given you any extra information that maybe you haven't picked up using conventional perfusion techniques, and particularly non-enhancing tumour recurrence or non-enhancing tumour progression?
Well, it was the first case that we have seen. There was no enhancement, so it was the lesion that has increased perfusion, so mostly grade 3 lesions that you have no angiogenesis but no enhancement. So for these lesions, it's very interesting because the ones that I look, usually there is less CTH increase, but it's quite punctual. And this is something that is interesting to see if this small sites of CTH increase are the sites where the lesion will eventually progress. So this is something that I think is interesting in these lesions without contrast enhancement, but already with some neoangiogenesis, and where we can see this. Another question is, and for this I still don't know the answer, but if for the lesions with no angiogenesis that we can detect with conventional markers, can we still have already some modification in OF or CTH? So this is something that we should explore more, but maybe there is also already something that is happening, and it will be very interesting to look at.
Other questions? One here.
Thank you for your talk. I just understand that you're investigating the new parameters. So can you tell us how big is your confidence if you see CTA alterations or OAF alterations in telling whether it's tumor recurrence or pure progression, for instance?
For now, my confidence is mostly case-based. It works good on the cases that I have seen, but we need to have something more documented, and that's why we are doing this study, multicentric and also with PET correlation, in order to increase our confidence and also increase the confidence of neuro-oncologists, neurosurgeons that we work on, because the goal is to decrease the time that we would wait before treating the patient or before operating him, and we should have the confidence in it. So I'm quite confident, but I really think that it's important to have these studies in order to document the confidence and be able to say that, yes, we think it's really a progression.
Thank you.
Could you remind us of how many patients was it that you were aiming to get, and when do you be so excited? When might you have the results of?
For the first study, we were aiming to have around 200 patients with the PET and MR from several centers. This is our aim.
Yeah, excellent. And any ideas of how long that will take? So you need to look at the data as well.
And hopefully we will present the final results next year. But if we can do it faster, will be better.
I'm not rushing.
It's
Thank you so much. Were
Thank
there
you.
any more questions? There was one here. Yeah.
Hi, thank you for the presentation. I saw that in some slides you talk about just RCBB, and in some others RCBB and RCBB corrected. Do you usually evaluate RCBB non-corrected?
No, actually, when I was talking about the corrected one, is to show you the difference between the non-corrected and the corrected. But yeah, we should always look on the corrected RCBV.
Okay, thank you.
Okay. There are no more questions. Thank you very much.
Thank you.